का नेम आ ही नहीं रहा है, कहने के मैं वेटिंग कर रहा हूँ।
हेलो
जी सर।
हेलो
जी 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 भाई
आ रही है
आवाज आ रही है।
जी 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 भाई अब आवाज आ रही है।
मेरी भी आवाज आ रही है।
जी 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 सर आवाज आ रही है सर, आपकी आवाज आ रही है।
अस्सलाम वालेकुम। Today's topic is a very simple topic. It's the gout. Gout is defined as a peripheral arthritis resulting from the deposition of sodium urate crystals in one or more joints. It usually involves one joint, single joint, and metatarsal joint, first metatarsal joint, and it presents acutely most of the time. It acutely, but it may present as a chronic case or chronic gout and recurrent gout. Now we start how it present. Basically, gout encompasses a group of disorders that occur alone or in combination. Hyperuricemia, the uric acid level usually increased in most of the cases, but in few cases there is in gout there is normal level of uric acid. The upper limit of uric acid in male and female is slightly different. In male it is 7 and in female it is 6. Now, attack of acute, typically monoarticular. It is an inflammatory arthritis. And sometimes it presents as a tophaceous deposition of urate crystals in and around joints. It may deposit in renal parenchyma as well and damage the renal parenchyma, and sometimes it forms a stone in kidney. So there is vast presentation, but the usual presentation is that it involves a monoarticular inflammatory arthritis, typically the first metatarsal joints. It affects less than 0.5% of the population. Means in 200, 1% is involved. Usually the male one is due to the familial predisposition, the incidence is very high. That is 80% in families affected by disorders. More common in male and less in female, but after 50 it's equal in both male and female, but before that it is more common in male gender. Now, gout typically sequence involve progression through asymptomatic hyperuricemia. Most of the time we see that the uric acid level is very high, like more than 10, but no symptom is present. So only asymptomatic hyperuricemia is present, and in some cases with hyperuricemia, patient present acute arthritis, acute inflammatory arthritis. Sometimes present as an interval, recurrent or intercritical gout. And in chronic cases, it deposited as a nodular mass of uric acid crystals in soft tissue. This is the Profacious gout or chronic gout, and also known as Harrison syndrome. So there is asymptomatic hyperuricemia, there is acute gouty arthritis, there is recurrent gout, and there is chronic profacious gout, in which nodular mass of uric acid crystal deposited in soft tissue, also called Harrison syndrome. Now, as in earlier I said that the urate saturates in plasma at 7 milligram per deciliter. So, in normal way, when the value is normal, it doesn't deposit. But when the level is exceed from 7, it is started deposition in tissues and as well in joints. Usually, this urate crystal is the monosodium urate crystals deposit in less vascular tissue like cartilage, tendons, and ligaments. There is a predilection for peripheral joints and tissues. So when they deposit, they produce symptoms. If they does not deposit, they don't usually produce symptoms. So sometimes very high level, even we see that the 15, 16 level milligram per deciliter, patient does not have any acute gout. And in some cases, we see that the patient present with acute gout and the uric acid level in blood is absolutely normal. So, in 25% cases, we have normal values, and 75% cases we have an increased value in acute gout. Now there is a primary gout, secondary gout. Now primary gout due to overproduction of the uric acid, and it is 10%. While primary gouts secondarily due to under excretion. Kidney is the excrete out this uric acid. When there is kidney fail to excrete uric acid, the level of uric acid is increased, and it is in 90% cases. The secondary gout usually develop when there is increased turnover, nucleoprotein turnover, like in lymphoma, in leukemia, and in other cancer. Secondary gout also happening in when there is increased cell proliferation or death, like psoriasis. There is rare genetic disorders, the Tehseen syndrome, in which there is also a secondary gout. Some pharmaceutical agents, medicine and drugs, may increase the level. Hello? Hello? Okay. Now, in acute attack, the patient usually the joint which is involved in this acute attack is the first metatarsal. Overalls, frequently nocturnal, usually in the night present, and there is excruciating pain. There is swelling, redness, tenderness, and there is when you palpate, you feel the heart. The area is hot, and it looks like that infectious, inflammatory, and infective. It seems like that. The swelling, redness, and tenderness is the main signs and symptoms. The first metatarsal, classically present, it is called podagra, but it may affect knees, wrist, and elbow as well. Sometimes it present with a multiple joint involvement, but usually the monoarticular involvement. In chronic cases, is destructive trophies. Much greater chance if untreated. If uric acid remains high for a long time and patient does not get any treatment, it deposits in his tissues, and sorry, I have some sore throat at the moment that I feel difficulty. I'm sorry for that. Much greater chance if untreated. Rarely it present as a chronic. Most of the time it present as an acute. Sometimes in chronic cases, it forms a renal stones, and it then produces symptoms like pain or infection along with renal stones, infection of the urinary tract. It may, if it deposited in the parenchyma, it then produce the nephropathy, uric acid nephropathy or urate nephropathy. So we have acute, we have chronic, we have tophaceous, we have renal lithiasis, and we have nephropathy. So uric acid, excessive uric acid may present like this. Now, there is some drugs which increase the production of uric acid. These are include the pyrazinamide. It's a drug which is used in tuberculosis, and usually these in the first phase, first 2 months, we give pyrazinamide along with other drugs, other anti-tuberculous drugs. These pyrazinamide increase the level of uric acid, but usually not develop acute. But patient have pain, but in joints present sometimes, and when we see the blood level, it is usually increase more than 10 in most of the cases, but does not develop acute. Low dose salicylate may also increase the level. There is diuretics, the loop diuretics, thiazide diuretics. These diuretics may increase the level. Some drugs like cyclosporin, tacrolimus, and ethambutol may also increase the level. Then we saw again a drug which is used in combination with tuberculosis. But some drugs also decrease the uric acid level by enhance the excretion from the kidney. And the most popular of one is the probenecid. The other drug is losartan, hydroxychloroquine, and fenofibrate and amlodipine. These, and there are some other drugs also do, but the most common these one. And the drug which act on the enzymes and inhibit the enzymes and decrease the level of uric acid, known as the xanthine oxidase inhibitor. And the two common drugs is the allopurinol and furosemide. Allopurinol is an old drug, and furosemide is rather a new drug as comparatively allopurinol. It is more safe to extend as compared to allopurinol. So these are the typical presentation you see on the left side. Podagra, the first metatarsal. It looks like infective arthritis, swollen, red, inflamed joints, and when you touch this joint, you feel hot. The area is hot as compared to other area. So it is tender, it is swollen, it is red, it is hot. On right side, the other joints, the metatarsal joint is involved. So it may involve any joints, like knee joints, elbow. So it may present, but usually present with a monoarticular, single joint. This is again, see on the right side, there is involvement of elbow. So another view, there is, you see the facius, a tophi is there, and here is the left one, the inflamed hands, the metacarpals are involved. Again, swollen and red and tender joints. So you see in the left picture, these are the positions of urate crystals, the chronic gout. This is another acute gout. This photograph, the joint is inflamed and red. And this picture usually not seen today, so because it's a very chronic complication of gouty arthritis when patient not treated, and then this type of abnormalities of the bony abnormalities you may usually not seen nowadays. It's an old picture. Now, how diagnose these cases? For the diagnosis, usually history and the physical examination is very important. By a careful history taken and physical examination, you almost reach the diagnosis, but to confirm it, you need some other things. You may aspirate the synovial fluid to arthrocentesis, and then you see a needle-shaped, negatively birefringent crystals, monosodium urate crystals within neutrophils and macrophages, or free floating. Here, these are the birefringent crystals. Usually, as I told you earlier, the uric acid level is non-specific. In 30% cases, you may have a normal uric acid. So, the uric acid level doesn't provide any clue in the diagnosis sometimes, because it some 30% cases it's a normal level. So we do uric acid level, but it does not add in confirmation of diagnosis is only by arthrocentesis. When you see the urate crystals floating or within the neutrophils and macrophages, these are the needle-shaped, birefringent, negative birefringent crystals. Urine collections when may show less than 800 milligram uric acids. This is underexplained. On less than 600 milligram urine-free diet. This is again microscopic. These crystals look like this. The negatively birefringent monosodium urate crystals. We do X-rays. In acute, there is nothing present in the joint, but there is soft tissue swelling. But in chronic cases, you see here, nothing is present. But here, this trophius torti, arthritis, extensive bony erosions, and sclerosis. And there's no joint space. There, joint space is present. There is no joint space. No joint space. So, sclerosis and joint space narrowing are seen in the first metatarso-phalangeal joint. One also has. So, X-ray usually doesn't add, except in chronic cases, we have some finding. But in acute cases, we do not have any finding, but soft tissue swelling. What are the differential diagnosis? The septic arthritis. It looks like septic arthritis and must be excluded. And these septic arthritis, when we exclude the joint, when we take out the synovial fluid, we examine the fluid and send for culture as well. And this rule out the infection. The second differential diagnosis is pseudo-gout, calcium pyrophosphate crystal deposition. may present like acute gout, but when we examine the synovial fluid, there is positively bifurcated calcium pyrophosphate crystals, not negative. So, and usually these people are older age comparative to gout patients. Another differential is the acute rheumatic fever. And palindromic rheumatism. This is sometimes in rheumatoid arthritis may present with the monoarthritis and they present periodically or recurrently. It is called palindromic rheumatism. This is a rare phenomenon. And psoriatic arthritis. In psoriatic arthritis, monoarticular involvement sometimes present with the nail changes, which is not present in the acute gout. Usually in psoriatic arthritis, there is pitting nail and different. When you examine the synovial fluid, there is no negatively bifurcated monosodium urate crystals. So the differential you usually differentiate very easily by examining the synovial fluid. Now, how do you treat these patients present with acute gout? What the level of uric acid? We usually not give at acute cases. We usually not give a drug which reduce the level of uric acid, because if you give like allopurinol or febutrostate, this may flare the case. So in acute case, you only have three main drugs: NSAIDs, colchicine, and steroid. You treat with these three drugs. And when the acute phase gone, then you start the drugs which lower down the uric acid level to keep the uric acid below 6. NSAID is one of the most important anti-inflammatory drug which is used in acute gout. It rapidly acts and reduces the pain as well as the inflammation. We can also use the colchicine for this purpose. 0.5 milligram orally, orally, or may require 6 milligram. And when we have response, we stop this medicine because it also has some side effects. When we aspirate, we start with the corticosteroid. After aspiration and diagnosis of acute, we start corticosteroid, and corticosteroid acts rapidly, and patients' pain as well as the inflammation inflammation subsides rapidly. And the most common drug which is used in Korea is the prednisone, or if you may use in the form of oral or as well as IV or intravenous. In some cases where these drugs not respond, there's refractory cases of acute gout. The one drug which is known as the anakinra, interleukin-1 receptor antagonist. We may use these anakinra in refractory cases. So the common drugs are NSAIDs, colchicine, and corticosteroids. So chronic cases. In chronic cases, we usually lifestyle modification is very important. Such person should have some diet restrictions. Usually these people who develop this chronic, they are overweight or disease. They must have encouraged to lose weight by doing exercise or by cutting calorie intake. On the diet, which is should be prohibited in chronic cases, or red meat, especially the organ meat, and seafoods. Beside this meat, and the meat extract as well. Usually people think that meat is prohibited and the extract is not. This is not the truth. The meat extract, usually people take yakhni, it should not be allowed in chronic cases. These also causes increased level. So the meat extract is also avoided. Limit the alcohol and other beverages which contain sweetener, fructose sweeteners. This increase the level of uric acid. So should not be used this type of juices which in which there is fructose used as a sweetener. And some medication should be prohibited, like aspirin, like diuretics, niacin, cyclosporin. So when the patient have a chronic or recurrent gout or acute gout, and with high level of uric acid, the uric acid maybe with lifestyle modification, including the diet restrictions and decreasing weight by decreasing weight. So we also decrease this level of uric acid by drugs. Uricosuric drugs. The excretion, we decrease it by increasing or enhance the excretion of the uric acid through the urine. And the probenecid is one of the most common drug which may be used for this. Sulfenpyrazole.
Toxic side effects.
toxic side effects, so we do not use for that. And patient must avoid, keep the kidney normal, avoid the renal diseases. Normal, keep the blood pressure normal.
Avoid renal disease.
Avoid NSAIDs, except in acute cases, because this may causes the nephropathy, NSAID nephropathy. So may exacerbate gout. In chronic cases, when allopurinol is indicated, allopurinol is a drug which inhibits the enzymes in the pathway of uric acid formation. So when you block this enzyme, the conversion of urine into uric acid is decreased. So we use when there is tophaceous deposits. These are the hard nodules formed by the depositions of the urate crystals in soft tissues. We also, this allopurinol is indicated when uric acid consistently more than 9 milligram per deciliter. Or patient had persistent symptoms with moderate uric acid level, or patient have impaired renal function, and in tumor lysis syndrome, when the uric acid level is increased, we use as a prophylaxis for tumor lysis syndrome. And here also NSAID to avoid exacerbation. Consider NSAIDs to avoid exacerbation. Now, how we manage between attacks? Our goal is to patient avoid the acute attacks. How we avoid acute attacks? By minimize the urate deposition in tissue and reduce severity and reduce this is only by we have a proper diet, which the item which must be, as I told you earlier, the red meat and some alcohol and some beverages which contain the fructose sweeteners, and some vegetables as well, like spinach, like beans and lentils and mushrooms. These and cauliflower. These may cause increase the high purine content diet should be prohibited. So not only the diet, the hyperinsulinemic medication, some medication which increase the level of maybe avoided. So use for that purpose some drugs to reduce production of uric acids like allopurinol and febuxostate. So between attacks, we should keep the level of uric acid below 6 to minimize the not only acute attack or recurrent attack, but deposition of urate crystals in soft tissue. Here again, I mentioned earlier, all meals, including seafood, is prohibited when there is high level of uric acid, and meat extracts as well, and all alcoholic beverages, beans, peas, lentils, oatmeal, spinach, cauliflower, mushroom. These are the also high protein diet and must be prohibited. These are the medicines which increase the level of uric acid in blood. The diuretics, thiazide diuretics, usually we use in the hypertension. So if some patient which also have a high hypertension, high blood pressure, should be avoided this thiazide diuretics. Some drugs have in combination. We have antihypertensive with thiazide diuretics. So thiazide may be avoided, and the loop diuretics, if not compulsory, may be avoided, except in some cases where if the patient have a cardiac failure case, where loop diuretics is necessary, then it may be given in low doses. Otherwise, in case where we can avoid, we should avoid. Niacin, low dose aspirin, this is also may cause. You may switch patient low dose, instead of low dose aspirin, you may switch some other antiplatelet like clopidogrel. Xanthine oxidase inhibitor drugs. These two drugs are very important, and we usually use these two drugs. Allopurinol is an old drug, and febuxostate is comparatively a new drug. Both have excellent way to decrease, but in kidney diseases where the level of creatinine is increasing, febuxostate is better choice. Allopurinol should be avoided. And uricosuric drugs, probenecid, we decrease the level through excretion of this uric acid. So these are three drugs, but two xanthine oxidase inhibitors, the most commonly used for decreasing. And when we keep the level below 6, usually there is decrease the recurrence of acute gout. Now the prognosis. What is the prognosis of gout? Generally good. Usually a lot of patients have increased uric acid level and have acute gout. Doesn't develop chronicity because of these measures, and when use properly drugs and avoid certain foods and medicine, they remain free of symptoms. 50% progress chronic disease if untreated. Usually, patient got treatment and not progressed chronic disease. Usually, these cases present in middle age, but if it present in a young age, less than 30 years, then more severe course may be expected. And for the profile, if somebody have a hard nodule deposited in soft tissue, through surgical intervention, you may take this tophi out. So generally, the disease has a good prognosis. This is all about the acute gout. Any questions regarding?
Surgical intervention in the surgical intervention in the prognosis, generally good and prognosis, generally good and prognosis, generally good. More severe course when it is present more than 30 years. So 50% of progress, 50% progress to chronic disease. 50%. 50% progress to chronic disease if untreated. Intervention with
The one question is how to differentiate inflammation from an infection. It's very simple. When you take out the synovial fluid from the joint, you examine this fluid. Usually, when there is acute gout, there is increased cells. It's not too much, but in an infection, there is more than 50,000 cells, and the culture is positive. But here, there is negatively birefringent crystals is present in acute gout, not in infection. And the second question: how do we differentiate between overproduction and this is again we examine the urine, the level of the uric acids in the urine, and when this is less than 800, it means the excretion is less. So you can easily find out that there is the this is not the overproduction, or maybe sometimes the overproduction and under excretion both, but the urine excretion through through urine excretion, you may find this under X-ray treatment. Hello.